Bismillahirrahmanirrahim. Assalamu alaikum. In this video, we discuss the second part of systemic antifungal drugs for systemic infections. In previous video, we discuss in systemic antifungal drugs, we discuss flucytosine and amphotericin B. Here we will discuss about azoles and echinocandins. Azole, what are azole? Their mechanism of action, ADR uses. We all are discussed by me in this video. Azoles containing drugs are fluconazole, ketoconazole, miconazole, clotrimazole, voriconazole, posaconazole, itraconazole. But we memorized them by this formula FKMC VIP. Azoles are synthetic compound. We classify azoles according to the nitrogen atoms in 5-member azole ring, triazole and imidazole. In triazole we have 2 nitrogen atoms, while in imidazole we have 3 nitrogen atoms. Triazole consists of fluconazole, itraconazole, voriconazole and posaconazole, while imidazole contain ketoconazole, miconazole and clotrimazole. These are azoles which are classified on the basis of nitrogen atoms in 5-member ring. Ketoconazole, miconazole and clotrimazole, these are used topically because we can't use them systemically because of their ADR. So we use them topically to treat skin related infections. What is the mechanism of action of azoles? First, the azoles is used for candida, Cryptococcus neoformans, endemic mycosis, dermatophytes, and aspergillosis and P. boydii. In endemic mycosis consists of blastomycosis, coccidioidomycosis, histoplasmosis. Now we will discuss azoles mechanism of action, how it works. What is ergosterol? Ergosterol is the sterol of fungal cell membrane. It is formed by the linosterol. Linosterol is the precursor of ergosterol. Ergosterol is made from the linosterol with the help of enzyme 14-alpha demethylase. 14-alpha demethylase. This enzyme removes methyl group from linosterol and convert linosterol into ergosterol. But azole do what? Azole inhibit this enzyme 14-alpha demethylase, so linosterol cannot convert into ergosterol. So this linosterol convert into the 14-alpha methylsterol in the cell of fungi. This inhibition led to the accumulation of 14-alpha methylsterol in the cell. This is harmful and damage the fungus cell. In the cell, the lysis of fungal cell occur due to the accumulation of 14-alpha methylsterol. Actually, this 14-alpha demethylase is the cytochrome P450 enzyme of the fungal cells. These azoles have greater affinity for cytochrome P450 of fungus and less affinity for human cytochrome P450, so they exhibit a lesser degree of they have less toxicity as compared to amphotericin B. While the imidazole exhibit a lesser degree of selectivity than the triazole, so imidazole have higher incidence of drug interactions and side effects. Resistance also develop against azoles by multiple mechanisms. What is the ADR? ADR of the azoles. These are non-toxic but minor GIT related ADRs are present. Azoles have minor GIT related ADR. Also, it causes rare hepatitis and abnormalities in liver enzymes. Drug interactions of azole uh, actually it has less affinity for cytochrome P450 of humans, but sometimes while some member of the azole have affinity for cytochrome P450 of humans, this drug azole inhibit the cytochrome P450 of human, which led to the serious toxic effects in human beings. Now we discuss the drugs of azole containing drugs one by one. Ketoconazole. What is ketoconazole? Ketoconazole, it is first oral azole. First oral azole is the ketoconazole. It is distinguished from triazoles by its greater propensity to inhibit mammalian cytochrome P450. It has greater affinity for cytochrome P450, so of cytochrome P450 of humans, so it has more ADR than other azole drugs. Less selectivity for fungal cytochrome P450, so we not use ketoconazole for systemic infections. We use it topically. Next is itraconazole. Itraconazole, it is also the member of azole drugs. It is used orally plus IV. Parenterally, use orally and parenterally. The dose of itraconazole is used 100 to 400 milligram per day. The absorption of itraconazole is increased by food and by low pH. Its absorption is increased by food and by low pH. When we take food, the acid secretion is more in our stomach, which led to the decrease in our pH, and which is favorable for itraconazole absorption. Itraconazole interact with hepatic enzyme less than ketoconazole. Its interaction with hepatic enzyme cytochrome P450 less than ketoconazole, so it is safe as compared to ketoconazole and have less ADR as compared to ketoconazole. Drug interactions of itraconazole reduce what is their drug of interactions? Itraconazole bioavailability is reduced by the rifamycins. Rifamycins reduce the bioavailability of itraconazole. Rifamycins like rifampin, rifabutin, rifapentine, they decrease the bioavailability of itraconazole. It doesn't affect mammalian steroid synthesis, so it is safe for humans. It is potent antifungal agent. Itraconazole is potent antifungal. Oral and parenteral use cyclodextrin as a carrier molecule to enhance solubility and bioavailability. We use cyclodextrin to enhance bioavailability and solubility of itraconazole. Like ketoconazole, it also poorly penetrate in CSF. It cannot cross blood-brain barrier like ketoconazole. It is used to what is the uses of itraconazole? It is used to treat dimorphic fungi, histoplasma. Itraconazole is used to treat dimorphic fungi infections, histoplasmosis, aspergillus infections, which aspergillus cause aspergillosis. But nowadays itraconazole is replaced by the voriconazole. Nowadays we use voriconazole to treat aspergillosis. It is also used to treat dermatophytosis and onychomycosis. These are the uses of itraconazole. Now we discuss the fluconazole. Fluconazole is available in, we have oral plus IV agents of fluconazole. It is water soluble. Fluconazole is water soluble, so penetrate CSF. It can penetrate CSF. Orally we use, and its bioavailability is high. Less drug interactions because less affect hepatic enzymes. It is selective for fungal cytochrome P450, not affect our humans cytochrome P450, so have less drug interactions. We use its dose 800 to 800 milligram per day. We use 100 to 800 milligram per day fluconazole. It has better GIT tolerance, have widest therapeutic index of azole. Where we use fluconazole, it is used to treat cryptococcal meningitis. IV fluconazole is equivalent to amphotericin B in treatment of candidemia. To treat candidemia, we use IV fluconazole in place of amphotericin B because IV fluconazole is equivalent to amphotericin B. It is also used to treat mucocutaneous candidiasis and meningitis. High dose fluconazole often obviate the need for intrathecal amphotericin B. No activity against aspergillus or other filamentous fungus, so it is not used to treat aspergillosis. Prophylactically, we use fluconazole prophylactically in bone marrow transplant. In bone marrow transplant and in AIDS. We use it prophylactically for in bone marrow transplant to avoid the patient, to protect the patient from fungal infections. Now another azole drug is voriconazole. What is voriconazole? It is azole related drug related to the azole family voriconazole. It is available in IV and oral form. We use its 400 milligram per day dose. Orally, its bioavailability is 90% and it is less protein. It have less 24 protein in the plasma. Then itraconazole have less protein binding than itraconazole. Metabolized in the liver. It is metabolized in the liver. It inhibits cytochrome P3F4. So it has drug interactions and reduce the dose of cyclosporine. So we need to reduce the dose of cyclosporine, tacrolimus and HMG-CoA reductase inhibitor. What is the ADR of voriconazole? The ADR of voriconazole is rash. The ADR of voricanazoles are rashes, visual disturbance, blurring, change in color vision, photosensitivity, dermatitis. Mostly it related to the eyes. Uses where we use voriconazole to treat candida sp infection, dimorphic fungus infection and invasive aspergillosis. Voriconazole is less toxic than amphotericin B because it is selective for cytochrome P450. Now we discuss another agent of azole, posaconazole. Posaconazole related to the family of azoles. It is a newest triazole. Posaconazole is the newest triazole. It is used orally. We have oral formulation. Its dose is 800 milligram per day. We use 800 milligram per day in 2 or 3 divided doses. Its absorption is increased with food because when we take food, acidity is increased in our stomach. Excretion of acid is increased in our stomach. So the low pH enhance the absorption of posaconazole. Rapidly distributed in tissues, have rapid distribution in our tissues. Broadest spectrum of it has broadest spectrum of azole family, used to treat candida infection, candida infection, aspergillus infection, aspergillosis, zygomycosis, mucormycosis, mucormycosis. Prophylactic during chemotherapy for leukemia, also used for allogenic bone marrow transplant, is prophylactically with graft versus host disease. We also use it pusaconazole prophylactically during bone marrow transplant. Now we discussed echinocandins. What are the echinocandins? These are actually large cyclic peptides. These are large cyclic peptides linked to a long chain of fatty acids. Large cyclic peptides linked to a chain of fatty acids. In echinocandins, we have 3 drugs. Echinocandins are peptides, cyclic peptides linked to a long chain fatty acids. We have 3 drugs in echinocandins: capsofungin, micafungin, and anidolafungin. These 3 drugs belong to the echinocandins family. Where we use echinocandins: the infection causing by candida, aspergillus, infection caused by the aspergillus like aspergillosis, not for Cryptococcus neoformans are the agents of zygomycosis and mucormycosis. These echinocandins only available in IV form. We have not any oral form of echinocandins. First we discuss capsofungin. Capsofungin, it is administered as a single loading dose of 70 mg. First we give 70 mg loading dose. Then we follow this loading dose by a daily dose of 50 mg. Capsofungin is water soluble. It is water soluble, highly protein bound. Capsofungin is highly protein bound. Half-life of capsofungin is 9 to 11 hours and it is excreted in kidney and feces. We adjust the dose in hepatic impairment. We adjust the dose in hepatic impairment. When we have hepatic impairment, then we adjust the dose of capsofungin. What is the uses and pharmacokinetic properties of micafungin? Micafungin have half-life of 11 to 15 hours. We use 150 mg per day dose of micafungin. For what? For which disease? For Candida esophagitis. For Candida esophagitis, we use 150 mg per day micafungin. 100 mg per day of micafungin is used for candidemia, while 50 mg per day used prophylactically for fungal infections. Anidolafungin is used for esophageal candidiasis and candidemia. It has half-life of 24 to 48 hours. For esophageal candidiasis, we give 100 mg of anidolafungin, 100 mg dose of anidolafungin loading dose. We give 100 mg loading dose of anidolafungin in esophageal candidiasis, and then this loading dose is followed by 50 mg per day for of anidolafungin for esophageal candidiasis for 14 days. For 14 days we give 50 mg per day anidolafungin. For candidemia, we give loading dose of 200 mg. Then this 200 mg is followed by 100 mg per day for 14 days. To treat what? To treat candidemia. Mechanism of action of this echinocandin is to inhibit the synthesis of beta 1,3-glucan. We inhibit the beta-1,3-glucan. Beta-1,3-glucan synthesis is inhibited by echinocandins. When we have no any beta-1,3-glucan, this led to the disruption of cell wall of fungus, and then the death of fungal cell occur. When the cell wall is disrupted, this led to the death of fungus. Beta-1,3-glucan is synthesized by the enzyme glucan synthase. Actually, this enzyme this drug echinocandins block the enzyme glucan synthase, which is need during the formation of beta-1,3-glucan. This glucan synthase form the beta-1,3-glucan, but this enzyme is inhibited by the echinocandins. So the formation of beta-1,3-glucan is inhibited, and the disruption of cell wall occur, which led to the death of fungal cells. What is the ADR of echinocandins? Mostly these are relative to the ADR is relative to the GIT. Capsofungan plus cyclosporine is avoided mostly. We avoid capsofungan and cyclosporine combination because it increases the hepatic enzymes. Micafungan increase the level of nifedipine, cyclosporine, sirolimus. How? Because it interact with the liver enzymes and increase the level of nifedipine, cyclosporine and sirolimus. Anidolafungan IV infusion, when we give its IV infusion, it led to the release of histamine. So this histamine cause allergic reaction, or we call it hypersensitivity. Led to the hypersensitivity. Clinical uses of echinocandins is mucocutaneous candida infection, used for mucocutaneous candida infection, used for disseminated infection, for febrile neutropenia by replacing amphotericin B, used to treat febrile neutropenia by replacing amphotericin B. Capsofungal is used as salvage therapy, used in invasive aspergillosis. It is used in invasive aspergillosis. Only as salvage therapy in patients who have failed to respond to amphotericin B, not as primary therapy. We give capsofungan in those patients who have failed to respond to amphotericin B. We doesn't use it as a primary therapy. We use capsofungan as a salvage therapy. Micafungan is used for mucocutaneous candidiasis, candidemia, prophylactic for candida and bone marrow transplant. Anidolafungan is used to treat esophageal candidiasis, invasive candidiasis and candidemia. These are the uses of anidolafungan use.